In the last lesson, I mentioned that I wanted to cover the enlargement of chambers as we see them really manifest on the 12-lead EKG before finally moving on to talk about ischemia and infarction. We started off with atrial enlargement, so now let's move on to the enlargement of the ventricles, aka ventricular hypertrophy. Alright, I welcome you guys back to another video lesson from ICU Advantage. For those of you who don't know me, my name is Eddie Watson, and my goal with this channel here is to try to give you guys the confidence to succeed in the ICU by taking these complex critical care subjects and making them easy to understand. I truly hope that I'm able to do just that. If I am, I do invite you to subscribe to the channel below. Make sure you hit that bell icon though, that way you never miss out when I release a new lesson. Now also, if you do enjoy these lessons and you'd be interested in getting CE credits for following along with them, then head on over to icuadvantage.com/academy and join the ICU Advantage Academy, where you can watch all these videos. You'll have access to all the notes, including the new notes that I'm currently working on updating, as well as audio-only versions of these lessons. And most importantly, you'll be able to actually earn CE credits for participating in this education. So I've got some great deals going on over there, so make sure and check that out. Now, if you would like to support the channel but really don't have a need for the CEs, or if you just want access to things like the notes, then you might also want to take a look at either the YouTube or Patreon memberships. Again, links to both of those. All that stuff is going to be down in the description below. Alright, so to get in and start things off, we're going to begin talking about our QRS complex wave composition. So we previously discussed the composition of this QRS complex, with it usually consisting of our Q, R, and S wave. That said, we don't normally see all waves in all complexes in all leads. The waves that we see, though, are combinations of the combined average direction of electrical activity in the heart at that moment in time, and really relative to the electrode that's particularly looking at the heart. So remember, if we take a look at our heart here, remember that the septum is typically going to depolarize first. This is then going to be followed by the ventricles, really overpowered by that main left ventricle going in that inferior and lateral direction, and then on to the rest of the ventricle, which is depolarized from the inferior to superior direction. So remember, though, that these are not just discrete events, though. In fact, they actually flow together over time. So if we actually look at this from the frontal plane looking at the heart, let's say if we're looking at lead 2, we can see with our complex here that we have each of the directions of electrical activity that over time are contributing differently to the waveform that we see. And then we can see as the colors kind of blend together, this is signifying that we don't just have those discrete events of electrical activity, but they're all kind of happening, together over time and then sort of flowing together. So the same concept we can also apply to our precordial leads when we're looking at the heart in that horizontal plane. So here, if we take a look at our 6 precordial leads from V1 to V6 in relation to our heart on the horizontal plane. So we have the same depolarization from the septum to the main left ventricle in that lateral inferior direction, and then on to the rest of the ventricle in a superior direction. This then gives us the following complexes as we see them for each of the 6 precordial leads. And we can see how here that the different moments in time, the different depolarization events have the effect on the different waveforms that we see in each of these leads. And you can see how when we transition from V1 to V6 and we move from a more rightward view of the heart to a more leftward view of the heart, that the waveform here is changing. So now we can have various pathologies that can really affect these complexes and their amplitudes. So for an example, previously we mentioned in a past lesson that we can see reduced size of these complexes in patients that have pathologies that inhibit conduction, such as COPD, obesity, and pericardial and pleural effusions. On the other hand, we also have various pathologies that can alter the flow of this electrical activity, so think our bundle branch blocks, as well as things that can actually increase the size or the amplitude of these complexes. So if a patient has had an MI and we've had an area of dead tissue, that this is actually not going to block or slow down any electrical activity through there. This can actually allow the signal to move through the tissue more easily, leading to a larger waveform. Also, if there's an enlargement of the tissue, either through stretching or through thickening, that this can also lead to more electrical activity, giving us larger waveforms. And in this lesson, that's specifically what we're going to be looking at is the enlargement of a ventricle or ventricles. Again, something that we refer to as ventricular hypertrophy. All right, so on this topic, let's go ahead and move on and start talking about left ventricular hypertrophy. And so as the name suggests, this is going to be enlargement of the wall of the left ventricle. Now, in general, ventricular enlargement is really going to be the result of two primary issues. So we either have some sort of outflow problem. So here the heart muscle must contract against a strong pressure that's either coming from high blood vessel pressure, so think hypertension, or a stenosed valve going from the ventricle to the blood vessel. So another example would be like aortic stenosis. Or we can see the enlargement as a result of some sort of dilation or volume issue. So this is a volume overload. And this could be like a valve that's leaking blood back into the heart after it's emptied, but some sort of volume issue that's going to lead to dilation and enlargement of that ventricle. So we actually have many different proposed ways to determine if we actually see or have evidence of left ventricular hypertrophy present on our EKG. All of them involve looking at either R waves or S waves. So let's actually make sure we're on the same page with these. So the R wave, that this is going to be the first positive deflection that we see in a complex, while the S wave is the negative deflection after the positive deflection, or if the only deflection that we have is negative, then this is also our S wave. So the two most common criteria for looking at and identifying left ventricular hypertrophy that we're going to use here look at either the precordial leads or the limb leads. I'll go over some examples in a second here, but let's talk about the criteria that we use. And one important thing to keep in mind is for each of our EKGs that we're evaluating, we really want to evaluate both of these because sometimes we can see criteria being met with one of these and not with the other and vice versa. So they both are pretty quick to roll through. And when we do our examples here, we'll actually look at both of these as well. All right, so the first is going to be the Sokolow-Lyon criteria. And this is the most commonly used one, and this is actually looking at our precordial leads. So here we're going to add the voltage or the height of the S wave in V1 to the voltage of the R wave in either the larger of V5 or V6. After we add them together, we're going to see if our total is either greater than 35 millimeters if the patient is greater than 40 years old, greater than 40 millimeters if they're 30 to 40, or greater than 60 millimeters if they're under 30, or at least in terms of adults. Now the next criteria is something that we call the Sokolow-Lyon standalone criteria. And this is a simpler look at the limb leads for this criteria. And here we're actually looking for the height of the R wave in our limb lead AVL. And to meet this criteria, it needs to be greater than 12 millimeters. Now, having met criteria for either of these, we would consider the patient to have met criteria for left ventricular hypertrophy, and certainly stronger evidence if both are present. So one thing to note, though, with the left ventricular hypertrophy that I will be discussing in the next lesson more is that similarly to what we can see with our left bundle branch block, we can also see ST segment elevation, something we call left ventricular hypertrophy with a strain pattern, but it's not indicative of a STEMI. So this presentation can often look like an acute anterior STEMI, but again, we will discuss that more in the next lesson. All right, so let's take a look at a couple examples of left ventricular hypertrophy, and let's see how we can see the criteria in them. So here's going to be our first example here. And so to start off, we need to take a look at our precordial leads, V1, and then either V5 or V6. Looking at the voltage or the height of the S wave in V1, if we count up from our isoelectric line down to the bottom of our S wave, we can see that we have 15 millimeters. And so now if we look at lead V5 and V6, it is pretty close, but I do think our biggest wave can actually be found in V5. And if we look at the voltage of the R wave here, it looks like, again, from the isoelectric line to the top of our R wave, looks like we have about 16 millimeters. So if we add V1 and V5 together, we get 15 plus 16, which gives us 31 millimeters. So regardless of the age of the patient, even if they're greater than 40 years old, we would actually be just shy of meeting criteria for left ventricular hypertrophy looking at our precordial leads. But like I said, we don't want to do just the one criteria. So next, we actually want to take a look at our standalone criteria for the limb leads. And again, here we want to look at AVL. So if we look for the largest R wave that we have here, for example, this one here, we would find that we have a voltage that's just over 12 millimeters. So this would barely meet criteria for us to call this left ventricular hypertrophy in this particular patient. All right, so hopefully you can kind of see how we roll through those different criteria and make that determination. Let's take a look at one more example specifically for left ventricular hypertrophy. Again, let's start off with our precordial leads V1 and either V5 or V6. So in V1, here is an example of a good waveform here. The voltage of our S wave in V1 here, this one's pretty deep, as you can see, going from the isoelectric line down to the end here. We're looking at about 28 millimeters. So then next we need to take a look at the voltage of the R wave in either V5 or V6. In our example, again, the height of the R wave in V5 I think is the larger one. So here is a good example of that, and it appears that we've got a height of about 37 millimeters. And so when we add up V1 and V5 together, we get 28 plus 37, which is 65, which is well above any of the criteria that we've got listed up here for any of the age groups that we discussed earlier. So based on this information, we would have evidence that we need to call this left ventricular hypertrophy. We don't want to stop there though, so let's also take a look at our limb lead and AVL for our standalone criteria. So here we'll take a look and we'll enlarge this waveform here, and we're looking at the amplitude of the R wave again, which you have a height of about 15 millimeters. So this is greater than the 12 millimeters per our criteria, so we can also use this as further evidence of left ventricular hypertrophy in this patient. Now, in this second example, I do want to quickly point out the presence of ST elevation in leads V1 and V2, some of our anterior septal leads, as well as ST depression in leads 1, AVL, V5, and V6, which would be our reciprocal lateral leads. Now, in the absence of left ventricular hypertrophy, this could appear as an acute anterior septal STEMI with those reciprocal changes in the lateral leads. But as I mentioned earlier, this is actually an example of left ventricular hypertrophy with strain pattern. Again, something I'm going to discuss a little bit more in the next lesson. All right, so in addition to seeing patterns that suggest left ventricular enlargement on EKG, we can also see criteria that would be consistent for patients with enlargement of the right ventricle, or what we call right ventricular hypertrophy. So with right ventricle hypertrophy, since the right ventricle is enlarged and larger, we're actually going to see greater electrical activity coming from that side of the heart. So one of the first indicators and the first criteria that we're going to look for is we're actually looking to see if there is a shift in the electrical axis of the heart into the right axis deviation. I'm not going to cover that here, so I'm going to link to a lesson up above on axis deviation if you do need a refresher on that. But then for the next criteria, once we have that, we need to take a look at V1. So we want to start off comparing our R to S ratio and checking if it's greater than 1. What does this mean? So essentially we're comparing the amplitude of the R wave to that of the S wave in V1. So remember that we have our R wave followed by our S wave, and if we put up two examples here, in this first example, our R wave is going to be smaller than our S wave, giving us a ratio of less than 1. In the second example here, we actually have an R wave that's bigger than our S wave, which would give us a ratio greater than 1. And if you remember, typically in our EKG, looking at our precordial lead starting in V1, we're expecting to see very negative waveforms that begin to become more and more positive as we move further down the precordial leads until we get to V5 and V6, where we generally have the largest positive waveforms. And so what we're looking for here in V1 is if that has flipped, and if we're seeing a larger R wave than an S wave in V1, this is looking at more of the rightward view of the heart. And so this would be an indication that we've got more electrical activity coming from the right side of the heart. So depending on the EKG, this may be something that you're able to tell on here just by eyeballing this, but more precisely, you can just measure out the voltage of each of the waveforms in small boxes and then figure out the ratio that way by dividing. Again, we'll cover this here in just a minute with an example. Now, we also want to observe if we have a QR complex that's present. So as you can see with this example complex here, with a QR complex, so if we have a Q wave that's followed by an R wave that's greater than 7 millimeters, that this is also another criterion, specifically, again, if we're looking at V1. Now, both of these are not going to be present, but we're looking for either one of these being present, and if either one is present in V1, that this is an indication of stronger forces on the right side of the heart. Again, remember that R wave progression, like I talked about, precordial lead starts very negative in V1 and transitions to positive as we move to V6. So on that last note, the last criteria that we want to look for is actually if we look at our leads V5 and V6. Here we're looking for the opposite pattern of what we just looked for in V1. Because like I just talked about, we're normally going to expect to see those larger positive complexes, which would give us an RS ratio greater than 1 normally. And so with that said, if we compare the RS ratio in these leads and the ratio is now less than 1, that this would also be an indication of stronger electrical activity on the right side of the heart. So it was a little bit more complicated of a criteria than with the left ventricular hypertrophy. So let's actually look at an example of right ventricular hypertrophy on an EKG and kind of talk through this, and hopefully that will make a little bit more sense. All right, so here is our example EKG here. And when evaluating the EKG for right ventricular hypertrophy, remember first we want to look at our cardiac access. So this example that I have here isn't set up like how we normally expect to see them, nor does it show us the computer's interpreted numbers and all that stuff. But I will go through this real quick, but make sure you refer back to that lesson on cardiac access if you do need a refresher on this part. So we want to look for our most isoelectric line, which is going to be present here in AVR. Thus, we know that our perpendicular lead to AVR is going to be lead 3. Here we have an upright wave in lead 3, which then if we look at our hexaxial reference chart, we see that a positive lead 3 gives us an axis of 120 degrees, putting us in the bottom right quadrant and indicating right axis deviation. So this is our first criteria met, and this is an indication that we have greater electrical activity coming from the right side of the heart. Now, having right axis deviation, we need to take a look at V1 and see if we have a RS ratio that's out of whack or those QR complexes. So in our example here, we don't have QR complexes, so we're going to look at our RS complexes in V1 and look at that RS ratio. Here it's pretty obvious just from looking at it that the R is much larger than the S, giving us a ratio greater than 1, being another indication of right ventricular hypertrophy. Now, if we did need to measure this out, we'd see that from the isoelectric line to the top of our R wave, we have about 17 millimeters. And then from the isoelectric line to the bottom of our S wave, it's about 5 millimeters. Thus, we would take 17 divided by 5, which is greater than 1. So finally, we want to take a look at either V5 or V6. Again, here we're looking for the inverse of what we were just looking at in V1. So we're still going to be looking at that RS ratio, but this time we're now looking for it to be less than 1. So looking at V5 and V6, they are pretty close in size. So for this example, let's just look at V6 here. Looking at the R wave and the S wave, they're actually pretty close in size. So the R wave looks like it measures out to about 10 millimeters, and the S wave looks like it measures out to about 10 millimeters as well. Therefore, we're right at a ratio of 1, which, while it technically doesn't meet the criteria in this lead to call this right ventricular hypertrophy, it is pretty close. And given that we do have findings of right axis deviation and that RS ratio being greater than 1 in V1, as well as just the fact that we typically would expect to see a pretty positive RS ratio in V5 or V6 at this point. So the fact that this is right at 1, I feel like we can pretty safely say that this patient probably meets the criteria for right ventricular hypertrophy. All right, so we covered a lot of information going over our ventricular hypertrophy, looking at both the left and the right ventricles, and really how we're going to be able to see that on our 12-lead EKG and identify that. So now that we've covered a lot of stuff looking at our 12-lead EKGs, we're finally going to move in and start to talk about our ischemia and infarction, our STEMIs, non-STEMIs, all that stuff over the next couple lessons. And then finally, we should be finishing up with the 12-lead EKG series. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.